Welcome to the Public Health Agency of Canada's webinar for healthcare providers. My name is David Alexander. I'm an assistant professor with the Department of Medical Microbiology and Infectious Diseases at the University of Manitoba's Max Rady College of Medicine and a laboratory scientist at Manitoba's Chatham Provincial Laboratory. I will be your moderator for today's webinar. The host of today's webinar is the National Collaborating Centre for Infectious Diseases. The NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning and policy. The NCCID is also supporting the agency with knowledge translation activities for the COVID-19 pandemic response. Earlier this week, we celebrated National Indigenous Peoples Day, and 2021 marks 150 years since the signing of Treaty 1. As such, I would like to acknowledge that the NCCID is located at the University of Manitoba in the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. Before we begin, I would like to mention some housekeeping items. We are running this webinar through Zoom. If you have technical problems with Zoom, please email nccid@umanitoba.ca. At the end of the webinar, there will be a question and answer period, at which time our panel will be answering your questions on the topic of SARS-CoV-2 variants and vaccines. To submit a question, use Zoom's Q&A tab. You can also like other people's questions to push them up in priority. Please wait until the end of the session to submit your questions, as our speakers will be addressing many common questions during their presentations. During the webinar, the hosts may use Zoom's chat tab for extra communication to attendees, so please keep an eye on that tab as well. The slides from each presentation and a recording of this webinar will be available at nccid.ca shortly after our session ends. I would now like to start with a brief overview of today's webinar. If we can move forward to slide 3, please. One more slide, please. So we have 3 major objectives today: to identify the national surveillance systems that detect and track SARS-CoV variants, including variants of concern in Canada. We'll discuss key findings on vaccine efficacy and effectiveness against the variants of concern. And finally, we'll summarize how predictive epidemiological models can inform Canadian forecasts and responses to SARS-CoV-2. It is now time to introduce our speakers and invite them to join me. Please turn your videos on. All of our speakers for today's webinar are affiliated with the Public Health Agency of Canada. Dr. Gary Van Domselaar will start us off with an introduction to genomic surveillance for SARS-CoV-2 variants. Gary is the head of bioinformatics at the National Microbiology Laboratory and a leader in the emerging field of public health genomics. Next, Lindsay Whitmore, a manager with COVID-19 epidemiology and surveillance, will discuss the epidemiological surveillance of variants. Our third speaker is Eva Wong, a senior epidemiologist with the NACI Secretariat. She will provide an update on the efficacy of COVID-19 vaccines against variants of concern. Our final speaker is Dr. Victoria Ng, senior scientist with the Public Health Risk Sciences Division at the National Microbiology Laboratory. She will discuss predictive modeling data as it relates to the variants of concern. Again, I'd like to mention that the webinar will finish with a Q&A session. In addition to the questions submitted today through the Q&A tab, our panel will answer questions submitted at the time of registration. We will try to answer as many questions as possible, but may not be able to address them all during the limited time allocated for today's webinar. And now, without further ado, I would like to welcome our first speaker, Dr. Gary Van Domselaar. Please begin as soon as you are ready.
Okay, thank you, David. And hello, everybody. Good day. I'm delighted to be here to present on Canada's National Genomic Surveillance Program for SARS-CoV-2. So next slide, please. All right. So I trust everybody is familiar with Canada's test, trace, and isolate strategy for controlling the spread of COVID-19. The test is a PCR-based test, which is rapid and accurate, and it's fundamental to our control strategy, but it only provides a positive or negative result. Genome sequencing, in contrast, provides powerful additional information that considerably enhances our ability to be able to understand, track, and control the spread of COVID-19 in Canada. So tracking transmission is a good example and one of the main applications of SARS-CoV-2 sequencing. As the virus spreads among individuals, it accumulates changes in its genome. And by capturing those changes through genome sequencing, we can piece together the transmission chains. But it also allows us to do more. So some, but not all. Some examples are, it allows us to monitor the effectiveness of our mitigation strategies, such as our border measures, by identifying new introduction of variants into Canada and potential onward transmission. Also very importantly, it allows us to detect viral characteristics that might impact detection methods, such as by identifying a mutation that would reduce the effectiveness of our PCR-based tests. Clinical outcomes by identifying strains that are associated with particularly severe disease, and importantly for this webinar, vaccine effectiveness by monitoring mutations on important viral proteins that vaccines target. Next slide, please. Okay, just one sec. Okay. So Canada's large-scale sequencing effort was launched in April of 2020, so about 14 months ago, through the formation of the Canadian COVID Genomics Network, which is led by Genome Canada with $40 million of federal funding. 20 million of that is dedicated to the viral sequencing effort called VirusSeq, and 20 million is dedicated for the sequencing of genomes of affected Canadians, up to about 10,000. I'm a founding member of VirusSeq, and I serve on the implementation committee. I've provided links to both of the different arms of the CanCogen if you're interested to find out more. Next slide, please. Okay, a lot of CanCogen's effort has been invested in increasing our national sequencing capacity, and that investment is paying dividends now. So the chart at the top shows our monthly sequence generation, which has been steadily improving. Our sequence capacity for May was over 30,000 sequences, and we project a total sequencing capacity of approximately 50,000 sequences per month. More importantly, though, than the number of sequences we generate is the sequencing rate, which is shown at the plot on the bottom. So higher sequencing rates give us better situational awareness of the variants that are circulating in Canada and reduces the time to detection of emerging variants that might require enhanced public control measures. Sequencing rate is a function of the number of sequences generated and the caseload, which is represented by that solid orange line in the top graph and the y-axis on the right. So our goal is to keep the sequencing rate above 10%, although with the following caseload and our increasing capacity, we could go much higher. The latest numbers, just checked actually just last night, and the latest numbers place our weekly sequencing rate at between 60 and 70% of total positive cases. That's one of the highest sequencing rates in the world. And as our capacity increases and our caseload decreases, we are on track to achieve a theoretical sequencing rate of 100% of total positive cases. Next slide, please. Okay, so our large-scale SARS-CoV-2 sequencing program was instrumental in forming Canada's early investigation and response to the emergence of variants of concern. So I don't have time to cover this slide in detail, but what's important to point out is that within a day of public notice of the first variant of concern, which was first detected in the UK, that's the Alpha or B.1.1.7 variant, we were able to search our database, which was approximately 25,000 sequences at the time, and confirm that no Alpha had been detected in Canada as of December 15. And so this important information was used to inform Canada's decision to suspend flights from the UK. Soon thereafter, we convened a rapid response group to provide guidance on genomic surveillance for the nation to be able to detect the Alpha and also the Beta variant, which was first detected in South Africa and was reported soon after the Alpha variant. That guidance was highly effective. Within 2 days, we confirmed the first detection of the Alpha variant in Ontario and in other provinces soon after. And of course, we've been detecting these variants and other variants of concern ever since. Next slide, please. Okay. All right. Well, so detection of the presence and spread of existing variants of concern is one important component of an effective genomic surveillance program for SARS-CoV-2. But equally important is the detection of new and emerging variants of concern. So genomic surveillance of SARS-CoV-2 in Canada is performed by federal, provincial, and territorial. So PT that you see in this slide stands for provincial and territorial by of experts called the Canadian SARS-CoV-2 Variant Surveillance Group, where we monitor for a variety of signals that indicate the presence of a new VOC. So genome sequencing allows us to monitor for variants that are associated with therapeutic failure, diagnostic failure, increased severity, increased transmission, and importantly, immune escape and vaccine escape. If that signal is sufficiently strong, then we can launch a national investigation. The outcome of these investigations are used to inform public health action. Next slide, please. This webinar focuses on variants of concern, but variants of interest are an important additional category of variants. So a variant is designated a variant of concern if there's sufficient scientific and epidemiological data to demonstrate that it's associated with increased transmissibility, or a change in epidemiology, increased virulence, or a change in clinical disease presentation, or decreased effectiveness of our available diagnostics, vaccines, therapeutics, or public health measures. Variants of interest are defined similarly to variants of concern, although the standard of evidence for designating a variant of interest is much lower than a variant of concern. It's important for us to be able to monitor them so to get them documented. So a VOI only needs to be predicted to have the attributes of a variant of concern, and then we can track it while we gather the more data that's needed to be able to provide that formal assessment to possibly redesignate it as a variant of concern. Next slide, please. So at this point, I'm going to turn the presentation over to my colleague, Lindsay Whitmore, who's going to discuss a little bit of the things on the case reporting and epidemiological side. Go ahead, Lindsay.
Thanks so much, Gary. So thanks very much for describing the genomic sequencing framework for surveillance. And I'm going to now go into how this information is incorporated into our national case-based surveillance for COVID-19. So I'm not sure if everyone on the call is familiar with public health surveillance and how it works, but it's based on a national case report form. We receive very detailed data from our provincial, territorial, or PT partners, as Gary already described, and we use the data in a variety of surveillance products to inform the public health response. And if you haven't done so, I invite you to look at the daily and weekly epidemiological reports available on canada.ca for more details. So as Gary explained, genomic surveillance has been ongoing throughout the pandemic, and the variant of concern, or VOC data, was incorporated into the national surveillance case-based system in February. So using this system, we monitor for the impacts of VOC on our case data. So here on this slide, it's a very high-level look at case numbers represented by the blue bars and the proportion or percentage of COVID-19 cases that are classified as VOCs, and that's the orange line. The y-axis is the number of total cases for that day nationally, and the secondary y-axis is the percentage of all cases being VOCs. VOC classification is based on both sequencing and screening results, but the proportions vary by jurisdictions and by individual variants of concern in terms of sequencing and screening. So as you can see in the blue bars, although the number of COVID-19 cases have been decreasing, the proportion of VOC cases shown in the orange is increasing to the point where at least 80% of all cases are now VOCs. I say at least because that peak is within the reporting lag designated there by the gray bar. It does take a bit of time for the VOC data to come through the case report system, so we anticipate about a month lag. So our estimates are that the true total of VOCs amongst our case data is actually much higher. The dip in the curve observed around May 1st is related to many aspects of the public health system being overwhelmed by the number of COVID cases, including jurisdictional abilities to do whole genome sequencing rather than screening. So that does not indicate a real dip in the proportion of VOCs. So moving to the next slide, please. Slide 13 here shows the composition overall of variants of concern nationally of all the cases known to be VOCs beginning in March 2020. So I just want to pay a bit of close attention to the labels here along the bottom. You'll see that the VOCs are here named with both their Pango and also the WHO label. So B117 alpha, for example, is in blue, beta in orange, P1 gamma in purple, and the red is the Delta variant. And we'll talk about that a little bit later. The labels that might be a little harder to understand are the screened beta gamma. So that is where screening designates that the sample will either be beta or gamma, but it has not been whole genome sequencing to discern which it is. And the other variant screened refers to reports from provinces and territories that indicate that the case is a variant of concern, but doesn't identify which one. It's a data quality issue that we're looking into. So overall, as you can see, we're seeing a decline in the proportion of B11 alphas being reported, and an increase in the proportion of gamma and delta cases, although the overall numbers of gamma are decreasing nationally. It's really the number of the delta cases that we're watching carefully. We are seeing an increase, and I'm sure that those of you who've been paying attention either professionally or personally through the news are knowing that this is the VOC under the closest scrutiny right now. Overall, the proportion of delta cases is quite low, around 5%. But as you've likely heard, this is not homogeneous across Canada. And what we're seeing in terms of the impact of Delta on our cases mirrors what's being reported in other countries. Transmission with Delta is occurring within younger age groups and through community transmission. The proportion of travel-related cases for COVID and Delta inclusive is very, very low. It's less than 5%. Severity is increasing with Delta. Delta cases are approximately 50% more likely to be hospitalized than Alpha cases after controlling for age in Canada. And although the vast majority, so greater than 98% of hospitalized cases are unvaccinated or partially vaccinated, we are seeing a higher proportion of Delta cases with one dose of vaccine than with the other variants of concern. So we need to reinforce the message about receiving 2 doses for full protection. That's my quick summary on the epidemiology. So Gary, back to you, I think, for your last slide.
Okay, thanks, Lindsay. Okay, yeah, so this is my last slide. And it's a little technical, but I ask that you please bear with me since it's important for understanding how genome sequencing relates to vaccine effectiveness and vaccine design. The top of the slide shows molecular models of the SARS-CoV-2 spike protein, which is the protein that binds to the human ACE2 receptor expressed in the lungs. The positions of the characteristic mutations for the alpha, beta, and gamma variants of concern are denoted for each model. The top right part of the model, I'm not sure if you can see, yeah, the top right where it's shaded in gray. That part is called the receptor binding domain, and it's responsible for attachment of the virus to the ACE2 receptor. The receptor binding domain is a major target for natural and vaccine-based immunity, and it's vitally important to know what mutations occur in this region and how they may impact vaccine effectiveness. 2 mutations that reside in the receptor binding domain that are implicated in immune escape and vaccine escape are the mutations at positions 417 and 484. What's also interesting to note is that these mutations are harbored by both the beta and the gamma variants, and they're starting to show up in the Delta variant. They've also arisen independently, which is an indication of convergent evolution that suggests that being selected for specifically because of their ability to evade natural and vaccine, their ability to evade natural and vaccine immunity. So this information is being used to develop modified vaccines that incorporate these mutations to maintain vaccine effectiveness as the virus evolves over time. And that ends my part of the presentation. Thank you.
So I guess now I will take over. So as a note before I begin, the vaccines discussed in this section include vaccines that have not yet been authorized for use in Canada, but they have an advanced purchase agreement in place, and they also have currently available data. Next slide, please. So to be able to determine vaccine impact on variants, you need the variant to be circulating, the ability to detect the variant, and a population that's getting vaccinated. We've been able to get some data on vaccine efficacy against variant strains from clinical trials that got off the ground a little bit later, or being run in places where variants began to emerge and they were able to sequence their samples and identify the variant. But for the mRNA vaccines, which were authorized earlier, we've had to rely on estimates of vaccine effectiveness from surveillance programs and community-based studies. So this next 2 slides will show the global spread of the 4 variants of concern. And these are based on reporting of variant genomes. And I'd like to note that these are general trends due to sampling and reporting biases. So starting out from the table at the top, we've included this table to identify countries involved in phase 3 trials because there was a period in time where we had to determine whether vaccine efficacy and also effectiveness estimates were being reported for the parent strain or being influenced by a variant strain to assess what information was available about the variant. Moving counterclockwise in the graph on the left, you'll see how the relative frequency of the alpha variant is trending over time. And there's a decline happening in a number of regions. And in data reporting up to June 14th, the decline is being observed in all of these regions. So moving on to the map with the red lines, this is a viral phylogenetic map describing transmission dynamics influencing viral phylogeny of the variant. So it's actually animated on the GIS aid website that's shown below. And so that might be of interest to some, seeing how the alpha variant is being detected around the world. The map on the lower right is the variant tracking, is tracking variant occurrence, and the circle size is proportional to the number of variant genomes reported, and the red dots being the most recent at the time the image was captured. If you go to the GIS aid website, the map now looks a bit different as the variants continue to be reported. Next slide, please. This is for the beta variant. Again, we have the list of countries where phase 3 trials are taking place. And going counterclockwise, this is the dominant variant that's being observed in Africa in the countries reporting variants. And so in more recent data, it's stabilized so that about half of the reported variant genomes are the beta variant in this region. In the phylogenetic map, you see how the movement and detection of the variant is different from the alpha variant, with quite a bit of activity between Europe and Africa, but also some to the other regions as well. And so that's reflected in the map on variant occurrence in the lower right. Next slide. And moving on to the gamma variant. There are fewer reported samples than the alpha variant, but more than the beta variant. And this is a dominant variant in South America. The phylogenetic map shows the movement between South America, Europe, and North America. And again, this is reflected in the map of variant occurrence. Next slide. And finally, the Delta variant, which is on the rise in all regions in the graph, reporting up to June 14th. And as the newest variant is causing a concern in a number of places. And we'll focus a little bit more about vaccine effectiveness on this variant in upcoming slides. So next slide, please. So how are the vaccines performing against the variants? This slide summarizes a qualitative assessment of any differences in protection or immune response, notably neutralization, for the variant compared to the original strain. This is adapted from a table in the WHO Weekly Epidemiology Report, and the summary is updated every few weeks. So vaccine protection against symptomatic disease and severe outcomes due to the alpha strain has generally been minimally affected for Pfizer and AstraZeneca vaccines. Although there isn't as much data for Moderna, it's typically considered equivalent to Pfizer. And so we can also consider protection against the alpha variant for the Moderna vaccine is also minimally affected. So for the beta variant, there's some limited evidence that suggests we should expect reduced protection, although protection against severe disease may be minimally impacted for the Janssen and Pfizer vaccines. We don't have great data on how vaccine protection is affected against the gamma variant, but some preprints looking at the situation in BC, where the gamma variant has higher circulation, have reported minimal reduction in protection from mRNA vaccines after a single dose as well as 2 doses. For the Delta variant, we currently only have information for the Pfizer and AstraZeneca vaccines as reported by Public Health England. So the protection you would get against symptomatic illness after 1 dose of AstraZeneca and protection you get after 2 doses of Pfizer remains virtually unaffected for the Delta variant. But the vaccine protection you get after 2 doses of AstraZeneca or 1 dose of Pfizer is lower. And so this might be better illustrated by looking at the actual estimates, which we have in the next slide. It was also recently reported that a single dose protection against hospitalization due to the Delta variant is not as affected and actually quite high. Next slide, please. So this slide is for those who like numbers and want to see the estimates of protection. It's summarized by vaccine product and variant, and we've included information about 1 dose and 2 dose effectiveness where the data is available. I won't go into too much detail here, but generally even against variants, you're getting a boost in protection after the 2nd dose for products that require a 2-dose series. And this boost is better with the mRNA vaccines. So just to reiterate, now that you can see the estimates, the vaccines were minimally affected against the alpha variant. We see some reduction against the beta variant, and we don't have great data for the gamma variant. For the Delta variant, 1 dose of Pfizer AstraZeneca has an estimated 33% effectiveness from symptomatic illness. And after two doses, protection from Pfizer is comparable to that for Alpha, but AstraZeneca is not. And we've actually recently seen updated data from Public Health England, where the protection after 1 dose may actually be a bit higher than initially reported as they have collected more data. And we're hoping that will get published in their weekly vaccine surveillance reports shortly. I think there's also potentially going to be a preprint coming out from data in Ontario that's also showing a higher first dose protection. And so what's not included here is that the 1 dose protection against hospitalization due to the Delta variant has been reported to be 71% for AstraZeneca and 94% for Pfizer, which is great news given the 1 dose strategy that has been used in Canada. And after a second dose, that protection jumps up to 92% for AstraZeneca and 96% for Pfizer. Next slide, please. And so this is the final slide for me, and it's on the future directions for variant-specific vaccines. So early in the year, various manufacturers have announced plans for trials involving variant-specific boosters and multivalent vaccines. Medicago and GSK have advanced purchase agreements with Canada, and so they're also included here. And now we're just waiting to see the results of their trials. And that's it for me. I guess I'll pass it over to Dr. Victoria Ng.
Great, thank you, Eva. Hi, everyone. So my section will be talking about the impacts of variants of concerns, and particularly from a modeling point of view. So next slide, please. This slide is just a general overview of the models that's currently being used by the Public Health Agency of Canada. So since February 2020, we've been working on developing a full range of different types of predictive and epidemiological models to inform Canadian forecasts and our response to SARS-CoV-2. Some of these were developed in collaboration with our academic partners, and many of them we've developed ourselves. And our models can be broken down into 3 main categories. So these are statistical forecast models, which are really very simplistic models that provide a short range forecast of reported cases given recent incidents, but there's no additional epidemiological or human behavioral data inputs in these models. Nonetheless, they can provide a very good estimate on the trajectory of reported cases, providing a 1 to 2 week forecast. Our second group of models are long-range forecast models. These models are adapted to project near future forecasts given recent incidents, and they do also include scenarios for control, release, and variants of concerns as well. These models can be used to forecast about a month or 2 into the future. So we call them the long-range forecast models. Lastly, we have a group of models which are a more complex group of dynamic models. They involve including including features of control, trying to control the epidemic in the model population. So initially they were developed to model control measures as needed, but more recently they've been adapted to look at the impact of vaccination rollout and the transmission of competing variants of concerns. So over the next 4 slides, I will show 4 models, scenarios based on the PHAC agent-based model, which is part of the 3rd group of models. These are recent models that we have explored in which we model COVID transmission in Canada with an alpha variant. And then progressively, we introduce a competing VOC, which is modeled on the Delta variant that is increasingly transmissible and virulent with immune escape features as well. So we don't actually introduce beta and gamma in the following slides, in the scenarios in the following slides, mainly due to data gaps on these variants and for simplicity, but we've been modeling a range of variants. And in each of these scenarios, we control the epidemic with frequent shutdowns and public health measures, which include physical distancing, case detection, isolation, and quarantine of contacts, in addition to the vaccination rollout. In the models, we will assume, in the models that I'm going to show, in which we do have vaccination, we assume approximately 75% of the eligible Canadian population is willing to vaccinate, which is currently based on Canadian behavioural survey data and real life data as well. For each scenario, I'll show some scenarios in which vaccination is not available and show the impact vaccination has had on the epidemic. So all of the scenarios assume we no longer impose restrictive shutdowns by mid-July, with lifting of physical distancing by early September. So in each of the 4 slides that I'm going to show with the scenario comparison, you can actually see a resurgence, at least in the without vaccination scenarios. And this resurgence is really due to us being able to control the epidemic to date because of all the public health measures that we've put in place. Next slide, please. So this is the first comparison. We have a without vaccination on the left and a with vaccination scenario on the right. So I'm going to focus more on the with vaccination scenario first. In this one, we only introduced Alpha variant in December 2020, as it was introduced in Canada around this time. The red horizontal line represents the number of hospital beds available for COVID patients nationally in Canada. There are no other variants modeled in the scenario. And for a very long time, this actually represented our baseline model when we were exploring the lifting of public health measures and what vaccine coverage threshold would it be safe to lift restrictive shutdowns and physical distancing. For the Alpha variant, we modeled it as being 50% more transmissible and 40% more virulent than the wild type, with no immune escape features. You can't actually see the 3 waves in that left figure. It's really quite small under the hospital threshold line. And this is partly because we wanted to show the without vaccination scenario on the same scale. On the figure on the right, without the vaccination and with the Alpha variant dominating transmission, when we do lift those restrictive shutdowns and physical distancing measures in July and September, respectively, we would anticipate approximately 75% of the population to be infected were we not to have vaccination in place. And this is reduced substantially because of both the vaccination rollout as well as our current public health measures, which has kept the healthcare system from being severely overwhelmed, though it's been pushed at times considerably. And you can't really see it, but on lifting under the scenario, with the vaccination scenario, there isn't really much of a resurgence. There's a little bit of resurgence, but it never really quite overwhelms a hospital healthcare capacity. And this figure actually shows the impact of vaccination. That what you see between the 2 figures and that resurgence and the non-resurgence under the vaccination rollout, that is really partly due to the public health measures that we've currently got in place, but really predominantly due to the vaccination rollout. Next slide, please. So in the next scenario, we introduced a Delta variant, and this is introduced on March 1st, 2021, to compete with the Alpha variant that was introduced in December 1st, 2020, excuse me. So the Delta variant is modeled as being 75% more transmissible than the wild type and 80% more virulent than the wild type with immune escape properties. So with the immune escape properties, we've modeled it as a 33% reduction in protection against infection after the first dose, giving it approximately 40% protection against infection according to the vaccine efficacies used in the model, and a 6% anticipated reduction for the second dose, which gives it approximately 86% protection against infection in the model. In this scenario, Delta is anticipated to dominate Alpha by September 2021, which is what we currently see in our surveillance data. What you actually can't see again are the waves in the resurgence after lifting of restrictive closures and physical distancing in the figure on the right. So with vaccination, there is a bit of a resurgence, and this resurgence is a little higher compared to the slide previously, because now we have a more transmissible and virulent variant of concern, but it is mainly controlled and it is below the hospital threshold capacity at lifting. On the figure on the left, you can see what this means, assuming that we don't have vaccination in place, we do see that resurgence, and it is a little higher because we have a more transmissible variant in circulation. Again, against a comparison, we can see the impact of vaccination has had overall on the epidemic. So the next 2 slides, I'm going to show a comparison of 2 hypothetical variants. These are not variants that we know currently. But with our modeling work, we like to explore some of the worst case scenarios and model things that we may not have seen but could see in the future. So next slide, please. So with this slide, oh, sorry, I realized we might have skipped one. Yes, thank you. So with this slide, this is the third scenario. This is a hypothetical variant that we're introducing against an alpha variant. We're introducing it on the same day that we previously introduced the Delta variant. So alpha comes into the population in December. This hypothetical variant comes in March. And the main difference is with this hypothetical variant, it has the same transmissibility and virulence as the Delta variant, but the immune escape properties are much higher. Here, we assume this variant has a 75% reduction on protection against infection that's afforded by both the first and the second dose of vaccine. So it's highly ineffective vaccine against the variant. It's highly unlikely we will encounter a VOC of this type, but we like to explore all the possible scenarios for worst case scenarios. And in the with vaccination scenario on the left, you can see that the resurgence is driven by the hypothetical variant. It is much higher than the previous figures that I showed. And it's also much higher in comparison in this figure to the previous waves that are also under that hospital capacity. And so we can see that with a variant with much immune escape, we will expect to see a much higher resurgence than our current waves. However, in comparison with the no vaccination scenario on the right, although the variant will have a considerable amount of cases, although the variant will cause a considerable amount of cases in the population, you can see how with vaccination in place, it is much reduced. Next slide, please. And finally, this is the last scenario. The only difference between the previous slide and this slide is that our hypothetical variant is now even scarier. It's now 100% more transmissible and 80% more virulent than wild type strains, rather than 75% more transmissible and 80% more virulent. The immune escape properties remain the same, and the resurgence post-lifting is a little bit higher, but not much higher. So what this indicates is that an increase in transmissibility and virulence in variants will make a difference in terms of transmission in the Canadian population. But it is really the immune escape characteristics that will make the highest and most impactful difference. And right now, we don't know what that is. We are using data that we get from published studies and from surveillance, but we don't really have a good grasp of what variants and their immune escape properties are. Similarly, with the previous slides, we have a no vaccination scenario in comparison, which shows again how important our vaccination rollout has been in controlling the epidemic. So if there's any key messages to be taken from our current modelling work, it is that vaccination is an extremely effective way to control the current epidemic, particularly against variants, as we currently do not know the full impact of variants. Without vaccination, we would be in a very different situation. Also, our model currently assumes that 75% of the eligible Canadian population is willing to vaccinate. If we were to increase the vaccine acceptance, this can only improve our current situation. So I understand that this is a very quick overview and a fraction of the work that we're currently doing at the Public Health Agency of Canada. We do have more information on our modelling on the NCCID website. So I'll conclude there. Thank you.
All right. All right, and with that, we conclude our final presentation from one of our key panel speakers. I would like to thank all of our speakers for sharing this wealth of information on variants of concern. I hope that you have learned a variety of things. If we can progress to the next slide, please. Great. I hope that you've learned through this webinar that Canada has a robust genomic and epidemiological surveillance system to detect and track SARS-CoV variants, including the emerging variants of concern. Also that Canada, in collaboration with other international bodies, are tracking the effectiveness of vaccines against SARS-CoV-2 and the many VOCs, including the alpha, beta, gamma, and emerging Delta variants. It's good to know that when a vaccine shows reduced efficacy against a particular variant, people who are vaccinated, especially fully vaccinated, still benefit from some level of protection. Overall, widespread vaccination will help all of us achieve the best public health outcomes by reducing overall transmission. Also, the modeling show us that despite the variants of concern, with vaccination, we can ensure that hospital capacity is not exceeded. Our speakers have left us lots of time for questions, so we will proceed with our question and answer session. However, I would also like to remind you, as shown on the next slide, that there are other resources available for keeping up to date on the rapidly changing scientific information available for our variants of concern. You can subscribe to NACI for publications and updates on immunization. If we go to the next slide, please. There's also a Public Health Agency of Canada Healthcare Provider Toolkit, which covers a lot of information, as well as advice on not only what the vaccines are, but how to improve confidence in our vaccines, reassure people how safe they are, and provide additional resources. I believe there's one more slide of other tools that are available. There are online tools for training. The National Collaborating Center for Infectious Diseases has a large number of webinars available. Indeed, among the questions was a question about mixing vaccines. And a lot of those questions were already addressed in an NCCID webinar a few days ago. I believe it was from CanVax and is available at www.canvax.ca. All right. So just before we begin the question and answer period, I would like to remind all participants the recording of this presentation will be emailed to you and posted on the NCCID website within a few days. And again, that website is nccid.ca. Past webinar recordings can also be found at nccid.ca. So we've had a variety of questions come through the chat. I'm going to start with one of those. And perhaps if we can go back to slide, I believe it is 15, with the models of the various spike proteins that Dr. Van Damselaar and Lindsay Whitmore described. And it has to do with the appearance of new mutations in variants. And I guess I'd like to expand this question. If our speakers could discuss how we are currently in Canada screening for variants of concern, even though our sequencing capacity and sequencing rates are much, much higher than they were at the beginning. Many provinces are still screening before they sequence, and through that rapidly capturing key mutations such as the 501Y and the 484K. You can go back one more slide, please. And one before that. There we go. So as you can see with the alpha, beta, and gamma variants on the next slide, the imaging shows that they all share a common mutation, the 501Y mutation. And this was our first trigger for looking for these variants of concern. And then the betas and gammas can be found by screening for the 484K. The Delta variant requires a different pattern, but as one of our audience members has noted, in their region, they are seeing 484K mutations associated with the Delta variants. And perhaps one of our speakers can address why that is happening, perhaps mention the Delta Plus variant and other components of the convergent evolution we are seeing with these, with SARS-CoV-2.
Well, thanks, David. I think that probably I'm most qualified to be able to answer that question. So you mentioned a little bit about our screening program. We didn't really talk about it much in this webinar, but so in addition to having the COVID test, which is a molecular diagnostic test, a PCR test that targets one or more regions of the viral genome. And beyond our genome sequencing program, we also have what are called variant-specific molecular diagnostic tests. And these are tests that are designed to target specific mutations in the SARS-CoV-2 genome, like the N501Y or the E484K. In fact, we also have one for K417N, and we have one for the Delta variant. It's called the P681R variant. And so these are like the regular testing. They can be deployed at scale, and they're rapid, and they give us that real-time situational awareness, whereas there's a bit of a lag time because of the effort required for whole genome sequencing. And so we combine both the specific screening and our sequencing technologies collectively to perform surveillance of SARS-CoV-2 in Canada. And I think the specific question was about the emergence of the E484K mutation. So this is the mutation that is associated with immune escape and vaccine escape, and is common to the beta and gamma variants and some other variants as well, some of the variants of interest, but also has been detected in sequencing that has been done in Ontario, so with the Delta variant. And so the E484K is not a common mutation in the Delta variant, but it has been detected in the, so there's a question about this, what is known about this variant or this mutation. And so, well, actually I was interested in that very question just yesterday, and so I was doing a little bit of searching around on the public archives, and I noticed that there are only a handful of sequences that have been deposited to the public archives. The recognized public archive for genome sequence information for SARS-CoV-2 is called GISAID. So there's 10 reports of the Delta variant that harbors the E484K mutation out of tens of thousands that have been deposited. So it's a very rare mutation, and most of the reports are coming from the United States, Pennsylvania, Texas, and New York, which are doing a lot of sequencing, and so that's where you're going to see it. But it also have occurred over a period of a couple of months, and so that suggests to us that that is a sporadic mutation that has not established itself and has not spread widely through the population so far. Because it is, and I would mention that this is a recurrent mutation with these other variants of concern, we're actually not surprised to be able to see that, just to see the E484K mutation arise in the Delta variant. And just like all the other mutations, we have a large watch list of mutations that we monitor for all the variants that are circulating in Canada. And so that's one of them that we continue to monitor for Delta. Thanks.
Thank you very much. Before I leave you, we have one other question that's just come through the chat, and it has to do with the PCR-based testing for variants and detection of COVID, and how that might be impacted, if at all, by vaccination. So once you are vaccinated, will that change how you respond to a PCR-based diagnostic test? I'm not sure who would like to take that question, but if someone could address the differences between the targets for PCR-based testing for diagnostic purposes and what the vaccine does.
Well, perhaps I could tackle that one as well. So the targets that are being used in the licensed tests in Canada by and large are very effective, and though we have seen occasionally where a mutation will accrue in a circulating variant that may affect one target, it normally doesn't abolish the entire test, which typically consists of multiple targets. So the test, the COVID test itself, I predict will be effective even post vaccination. The question, I think, is probably, well, the consideration, I think, that's more important than whether these mutations will arise that may affect our ability to detect the virus may be just the viral load that a person has. So the higher the viral load, the easier it is to detect by a COVID test. And so we are detecting reinfection and vaccine breakthrough infections with our with whole genome sequencing and with molecular diagnostic tests, but it could be the case that as your immune system presents a more robust response, that the viral load goes down, and that may diminish our ability to be able to detect it with our standard PCR-based tests.
Thank you. And if I'll just reiterate part of that answer. So vaccination itself does not affect anything that would alter the sensitivity or specificity of a PCR-based diagnostic test. So you will never get a false positive COVID result once you've been vaccinated on a diagnostic test. The variants themselves, because of the mutations they show, have the potential to interfere with some PCR-based diagnostic testing, but with the licensed testing we see in Canada, this has not been an issue. We are reliably diagnosing cases of the variant, and plus with the extreme power of the genome sequencing, we can follow up and still identify and classify all of the variants. All right, our next question. Several of our speakers have mentioned the term immune escape. I'm wondering if perhaps Eva Wong or Dr. Eng could kind of describe in detail what is meant by immune escape and why it is important.
So I can tackle that. I apologize for not having time in my presentation to explain that. And I actually just answered 2 questions on the chat on that, but I can answer it again. So immune escape from a modeling perspective is when there's a variant, usually a variant of concern. If we say that the variant of concern has an immune escape property, it means that it is able to evade the effectiveness of vaccines, protection against illness and infections and severe symptoms. So a variant of concern with immune escape has the ability to evade the protection afforded by the vaccines. A variant of concern with high immune escape means it is able to evade vaccination protection quite readily. And if it just has a lower amount of immune escape, it is able to just evade vaccine protection just by a bit. It reduces it, but it's usually not that much because the vaccines that we currently have been administering is quite protective, especially after the second dose. And so when I was talking about, I think a 6% reduction of the 6% immune escape from vaccines for the modeling work, we really see in the models we're assuming there's a 96% protection against infection with the vaccines. With immune escape, you would reduce that by about 6%. So it's about 86% or so. That's from a modeling perspective, but maybe Dr. Gary is going to provide a more technical definition.
Oh, no, I think that I think I accidentally started my video, but it wasn't.
Okay.
And while we have Dr. Eng on the line, I'm wondering if you could go into some more detail about the data used in modeling. Where does this data actually come from? How is it currently collected in Canada and used for these national modeling surveys?
Right, there's a lot of data that goes behind these models. I didn't really have the chance to talk about the technical details. All of our models are data driven, and the sources are coming from a variety of different places. So At the essence, we have surveillance data. So when we have the national surveillance data that we get from the provinces and territories, we have information about cases and their hospitalization and severe health outcomes. So we use that in the model to model the rate at which our population in the model go to hospitals, and we also have information on age. So we have an age-specific model for the agent-based model. We have epidemiological data to support the way that we model both the wild strain and the variants. So that is coming from data in the literature. We have a knowledge synthesis team within our division that scans the data, the literature on a daily basis, and then they feed the data to us and we input that into the model as well. And then of course, we also try to model sort of worst case hypothetical scenarios, and those are really just based on our sort of best guesstimates on what to expect. But generally our data are based on Canadian data. We try to, at the beginning of the epidemic, we were pulling data overseas because that's where most of the data was coming from. But as we got more and more Canadian data, we shifted and we were inputting Canadian data into the models, and then we scan the literature. So that's generally sort of where we get our data from.
Thank you. And personally, I've been actually very impressed and a little bit scared by how well the models have predicted some of the waves. For our next question, I'm going to perhaps turn this one over to Lindsay Whitmore. And it has to do with, I guess if you could reiterate some of the features of the variants that are out there, particularly with note to which ones might be more severe, or is there evidence that some are more severe, causing more death than our non-variant strains?
Oh yeah, so thanks very much for the question. And I think that's of course what everybody's watching. As I described in my presentation, yes, we are seeing greater severity. And so we often monitor that by hospitalizations, ICUs, and death. So ICU, I mean ICU admission. And we're watching all the variants of concern. And we are seeing greater severity for all variants of concern. But we are lucky enough to right now have kind of lower death counts or deceased cases reported than we have in the past. So, and the cases have been younger. So people have been following carefully. They know that the risk of death increases with age and increases with various risk factors. And right now, what we're seeing is, yes, an increased severity associated with all the variants of concern, particularly the Delta, but that hasn't necessarily extrapolated to increased to death. We are monitoring it carefully, and I think that we'll probably have something more conclusive to say in the future, but the numbers are very, very small right now. I saw another question, David, about I saw another question about reinfection. I wonder if you want me to talk briefly about that.
If you'd like to do so, that would be fantastic.
Sure, I will. Okay, so reinfection, that's another topic, right? That's getting a lot of attention. And once we have COVID, can we get it again? And this fits into what Dr. Ng was just saying about immune escape. So right now, we're working on a national definition for reinfection. It sounds simple, but it's actually very, very complicated. But our partners in public health, from the local to the provincial and territorial levels, are monitoring reinfection. And what we know is that there's a very, very small number. So the P1 variant, the Gamma variant, was flagged as potential possibility for reinfection early on. So we've watched that variant very carefully and worked with our provincial and territorial partners to dig into the cases a little bit. There are a small number of cases of the P1 variant that are under investigation for reinfection right now, but it isn't making up a large proportion of the total cases. So while of course it's concerning that that possibility is there, we aren't seeing it in big numbers in Canada right now. But of course, I'd open the floor to my colleagues if they have anything to add on that.
Well, if there are no further comments about reinfection, I'm afraid we've reached the end of our hour. And that brings us to the end of our webinar on variants and vaccines. I would like to thank all of our speakers for their presentations, and also thank all of you for joining us. We hope the information provided will help you in your practice. The recording and slides from today's webinar will be available on the NCCID website. And as you leave the webinar, please take a few moments to complete a short evaluation. Your feedback is important to the planning of future events. Finally, to those healthcare providers in our audience and those working in vaccination programs, we thank you for your unprecedented efforts during the COVID-19 pandemic. Thank you and be well.